So twin reverse arterial perfusion, it's one of these rare and unique complications of monochorionic twinning. So first I'm going to talk about how they arise, then what is the expected outcome, the outcome after invasive treatment, and then a trial we are doing on the best time to treat this condition. Now, acardiac twinning, it's unique to monochorionic twin pregnancies because there are two conditions that are necessary for TRAP to develop. You have to have the early demise of one of a monochorionic twin pair, and that baby then becomes a true parasite. And you know, in a dichorionic setting, when you have two separate placentas, when one of the baby dies, then this becomes a vanishing twin syndrome. But obviously, in a monochorionic setting, you have the vascular communications, and that's the other prerequisite. You need an artery-to-artery anastomosis for blood to travel from the surviving baby towards its demised co-twin. And actually what happens is that the arteries in fetal life, they carry the oxygenated blood. Through the artery-to-artery anastomosis, deoxygenated blood goes in the opposite direction into the body of the demised co-twin, and therefore the name twin reversed arterial perfusion sequence. And that also explains the most common presentation of acardiac twinning, which is that you have a severely abnormal twin, but still a reasonable development of the lower limbs. And that's explained by the reversed flow of blood. So more and more oxygen is extracted. So you have mostly a rudimentary development of the upper body parts. Now, this is not an innocent condition because the demised twin becomes a true parasite that depends on the circulation of the co-twin, which we call the pump twin. So the healthy surviving twin is called the pump twin, and the demised twin is called the acardiac twin because it doesn't have any functional heart activity of its own. And the main problem is that it will cause high output cardiac failure in the pump twin, which will manifest itself by cardiomegaly, hydrops, tricuspid regurgitation, and also polyhydramnios. Now, this is a problem, but additionally, because oxygen is extracted into the tissue of the demised co-twin, very deoxygenated blood will travel back towards the pump twin through a vein-to-vein anastomosis. Now, the vein is supposed to carry oxygen-rich blood, and the admixture of this very deoxygenated blood will cause a decrease in total oxygen delivery towards the pump twin. And that's a concern, and what has been shown in a recent publication is that indeed, because of this decrease in total oxygen delivery, the pump twin will show signs of brain sparing. So you will have a decrease in the pulsatility index of the middle cerebral artery and compared to the pulsatility index of the umbilical artery. And so there is a concern that if you don't treat acardiac twinning, that this may have a negative impact on neurodevelopment, because this is the same pattern that we see in growth-restricted babies, and that correlates with poor neurodevelopmental outcome. Now, just on the natural history, so it occurs in the older literature, you find that it occurs in 1% of monochorionic twin pregnancies, but actually, since we now see monochorionic twins already in the first trimester, and we see more acardiac twinning in the first trimester, we know that it's probably a little bit more common. It's 2.5% of monochorionic twins, so 1 in 15,000 pregnancies. So it's half as common as monoamniotic twins, and monoamniotic twins, which are 5% of monochorionic twin pregnancies, and we see in 1 in 7,500 pregnancies. Now, Cardiac twinning is much more common in a monoamniotic setting than in monochorionic diamniotic twin pregnancies, and that's because, like I showed you yesterday, monoamniotic twins, they have cord insertions that are very near to one another with huge anastomosis, and usually they have this large artery-to-artery and vein-to-vein anastomosis, which is a prerequisite to develop cardiac twinning. But since there are more diamniotic monochorionic twins, most TRAP cases are diagnosed in a diamniotic setting. And we put our cases together with the cases in King's College Hospital and looked at the outcome of a cardiac twinning diagnosed in the first trimester. And there we noticed that actually a significant number of pump twins are lost between the diagnosis in the first trimester and then the planned intervention at around 16 to 18 weeks. And if you were to manage these cases conservatively, and these are the figures from the observational studies when a cardiac twinning was diagnosed on the second trimester scan, we still know that there is a further 55% mortality in the pump twin because of cardiac failure and subsequent polyhydramnios related preterm birth. So in a cardiac twin pregnancy, it's important also to realize the mortality only refers to the pump twin because there's only one viable fetus in this setting. And the diagnosis should be made in the first trimester, and it's actually not so difficult. You have one normal twin, the pump twin, and then you have a very abnormal mass where you can recognize skeletal structures, often a spine or a femur, and very striking subcutaneous cystic edema. And then if you use your color Doppler and your pulse wave Doppler, you will see in the umbilical artery of this cardiac twinning, sorry, I have to use this, you will see in the umbilical cord the reversed blood flow going in the cardiac mass. And actually this was just the cardiac fetus was just a ball of tissue, but it had a rudimentary heart, and this bradycardic pulsations are from the rudimentary heart of the cardiac mass. And since it's difficult to predict the outcome, most European centers offer prophylactic treatment from 16 weeks onwards. And the reason why we don't usually do invasive fetal surgery in the first trimester is the same reason why we don't do amniocentesis prior to 16 weeks. So in this monochorionic twin pregnancy, there is a common exocelomic cavity, and the risk is that if you're putting a needle to this still shared common exocelomic cavity, that the risk of miscarriage is very high. So traditionally we offer treatment only from 16 weeks onwards. In the US, they are still more conservative. They offer only treatment if the cardiac to pump weight ratio is more than 50%, because in these cases, we know that there will be subsequent demise of the pump twin in 45% of cases, and there's also a 70% risk of very preterm birth. But in Europe, we prefer to do prophylactic treatment because the problem is that you will not always be able to predict demise of the pump twin. And also surgery later on in pregnancy can be quite difficult because of the hydropic umbilical cord of the cardiac twin. Now, the differential diagnosis, so that's very important. Whenever you diagnose a single demise in a monochorionic setting in the first trimester, you should call the patient back after a week or 2 weeks just to confirm that there is no development towards a cardiac twinning. And it's easy, you just use your color Doppler. This actually is also a hydropic twin that died, and it was in a heterokaryotypic monochorionic twin where the twin that passed away had Turner syndrome. And obviously in the cardiac setting, you will have this reverse flow through the umbilical artery. Another differential diagnosis is with the placental chorioangioma, and there obviously you don't have the skeletal structures present, and you don't have a clear umbilical cord, whereas in a cardiac twin you have the reverse flow in the umbilical artery. And what are the different presentations of a cardiac twinning? Well, this is the most common presentation, what we call acardiacus acephalus. This is, you can see there is reasonable development of the lower limbs, but the upper limbs and the head are absent. And then the second commonest form is what we call acardiacus amorphus, and that's where there's any recognizable structure present. And very rarely is the anceps form, where most body parts are developed, and even part of the face and rudimentary brain development. And then very rarely is only development of the head, where you have a head on an umbilical cord that is connected to the placenta. This is the rarest form, and I must say I've never seen it myself. Now for the treatment, Monique is going to address that, but just to briefly touch on it, our favorite treatment for diamniotic twin pregnancies is intrafetal coagulation, where you can, in the first trimester, you potentially could use laser, because then you can use the thin CVS needle and even a 20-gauge needle. But in second trimester, we would use radiofrequency with a 17-gauge needle. And survival rates for the pump twin are around 75 to 85%, with an average gestational age at birth of 35 to 37 weeks. A very good technique as well, especially in a monoamniotic setting, and if you have to transect the cord, and you should always do that in a monoamniotic setting, is to use laser surgery like you do for twin-twin transfusion syndrome, and actually the survival rates are pretty similar to radiofrequency. Bipolar coagulation we use a lot in for discordant anomalies in monochorionic twins, but it's a less good technique for a cardiac twinning, because often the cord is very short, or sometimes can arise directly from the cord of the pump twin. So this would only be the technique of choice, for instance, in a monoamniotic setting where you have a thick hydropic cord. So most commonly we use radiofrequency or laser intrafetal ablation in diamniotic twins, and then laser in the monoamniotic twin pregnancies. Now just briefly to touch on the trial we are doing, and the trial addresses the question whether we should treat them in the first trimester, or as we do up to now, treat them in the early second trimester. And just to illustrate these, we collected the outcome of 24 cases and a series combined with King's College Hospital. And what we noticed is that when the patients were diagnosed with TRAP in the first trimester and came back at 16 weeks, in 1 in 3 cases, we diagnosed that the pump twin had died. So the reverse flow had stopped spontaneously, but unfortunately also the pump twin had passed away. And then in about 1 in 5 cases, there was spontaneous arrest of the reverse flow, but the pump twin was still alive. And then when we looked at the outcome, actually only 2 out of these 5 cases led to a term live birth. In the other 2 cases, one was a miscarriage, and one was spontaneous subsequent intrauterine demise, and there was 1 termination. So actually the main message is that in less than half of the cases, they were still eligible for the procedure, and we performed mostly intrafetal laser coagulation. And for these cases, the outcome was pretty good, 90% delivered after 32 weeks. Now, just the main message is that when you look from the first trimester onwards, then it's true that if you tell the patient to come back at 16 weeks and then we'll treat the condition, that you have to tell the parents that, well, in about 1 in 2 cases, the surgery will no longer be necessary. But unfortunately, the survival rate when looking from the first trimester onwards was only 46%. Whereas as you look from the treatment at 16 to 18 weeks, then the survival rate was 90%. So there's a very high loss rate in the first and early second trimester of pregnancy. And another observation is that from a meta-analysis also published by King's College Hospital is that when you treat them earlier, the pregnancy, they tend to deliver later. So the earlier you treat in pregnancy, and you have the impression, and this was significant, that the first trimester cases, they delivered later than the ones treated later on in pregnancy. So that was the incentive for the trial to see if the babies that now die in the first trimester, can we save them by doing the surgery earlier, obviously without compromising the outcome for the ones that would have made it to 16 weeks, because you expect that the miscarriage rate will be higher. And so this is a multi-center trial, randomized controlled trial, that we are doing, and our primary outcome is survival and birth after 34 weeks. And we collected 30 cases, but we still have to go to 126, so every first trimester TRAP case is very welcome to be included in the study. And the study is called Trappist trial because I'm from Belgium and we like the Trappist beer. So as a take-home message, TRAP is rare, but it's important to know how to diagnose it. And it can be diagnosed in the first trimester. And it has very high loss rates if managed conservatively. And also what I didn't mention is that if you manage them conservatively, we also know that they, on average, deliver at 29 weeks. So there's not only the risk of demise, but also extreme preterm birth and therefore long-term neurodevelopmental impact. And invasive treatment is an option, and when you look for the cases that come at 16 to 18 weeks, there are good survival rates after treatment. Thank you.